Good afternoon, everyone. Good
Good afternoon,
afternoon,
sir.
learned colleagues, our guest speakers, my indefatigable chairman of Nba-Garki branch, and the chairman, our convener, chairman of the Medical and Health Law Committee of Garki branch. Um, you are welcome to November edition of our webinar series. We are to start by 3 p.m. Maybe I will just allow maybe 1 or 2 minutes and we'll kickstart. My name is Olatunji Atoibi and I'll be your anchor for today's webinar. Thank you very much. Welcome. We have a star-studded list for this series. We have Dr. Uchenna Ewelike, and we have Dr. Ifeanyi Sofo joining us this afternoon. Although made to understand that Dr. Ewelike is busy, he has an appointment with the state governor, and they've been involved with some other projects. So he's ably represented by uh, his representative, Mr. Obechuku Ibe, who is also joining us. So we welcome everyone, and we do hope that you have a wonderful time in this series. Thank you very much. And maybe in the comment section, we have also realized that we have friends and colleagues from under other branches of the NBA across Nigeria. You could just tell us where you are joining us from. Yeah, tell us NBA, so branch, so branch. We can see your name, so just tell us where you are joining us from and your branch, just your branch, and where you are joining us from this afternoon. Thank you very much and welcome once more. In the next 1 or 2 minutes, we are going to kickstart the webinar. Thank you. Mr. Tochukwu Ibe is with us, representative of Dr. Ewelike. Thank you. Good afternoon. Thank you very much. I can see our first comment joining us from Gariki Branch, Abuja. Thank you very much, Ingira Akinola. You're welcome. So I'm waiting for others to let us know where they are joining from. Yeah, thank you very much. Oh, thank you. Okay, Mbanaso, you are joining us from Humaya. Thank you from Samuel Hunakundu. You are joining us from Lafia. Thank you very much. Yeah. And our colleagues from Humaya, Mr. Okeobo. Thank you very much, Mr. Cornerstone from Ukwa branch. Thank you, even though we did request for your SCN, but it's just an introductory session, just to let us know where you are joining us from. When we get to the CPD point, we'll let you know, but it's just an introductory session before we kickstart. So in the next 30 seconds, I'm going to call on my chairman of the Medical and Law Committee of the Nba-Garki branch for his welcome address. He's our convener. Mr. Ebenezer Iguatu. Yeah, thank you very much, everyone. Good afternoon once again. My name is Atoy Belatunji, and I'll be your moderator for this edition, November edition of the webinar series for medical and health law webinar series for the November edition. And our topic is universal health coverage and health insurance, practical approach to mitigating out-of-pocket payment for healthcare in Nigeria. Yeah, so like I said earlier, we have a star-studded list for this session. We have Dr. Uchenna Ewelike, is the Executive Secretary or Chief Executive Officer of the Imo State Health Insurance Agency. And we also have Dr. Ifeanyi Nsofo, is from Universal Health Coverage and Health Insurance Equity Advocate from the United States of America. You're all welcome, sirs. If it were to be a physical gathering, I would have been expecting a clapping ovation. But since it's a webinar and digital, we cancel. But you're all welcome, sirs. So very quickly, I will just say a thank you to the chairman of the Nba-Garki branch, Mr. Anthony Bamidele Ojo. Thank you for this privilege. And also a thank you to Mr. Ebenezer Iguatu, the convener and the chairman of the Medical and Health Law Committee, Nba-Garki branch. Thank you very much, everyone. Thank you for joining us this afternoon. And special thank you to all our participants for joining us. Special thank you to all our participants for joining us this afternoon. So I'm going to call on the chairman, Medical and Health Law, Mr. Ebenezer Iguatu. Thank you very much, sir. Over to you.
Thank you, our able moderator. Good afternoon, distinguished gentlemen. At the bar, we do not have ladies, but I'm aware there might be a few persons who are not legal personnel or persons here. So based on that, I'm going to say good afternoon, ladies and gentlemen, and welcome to the October edition of our monthly medical and health law webinar organized by the Garki branch, the Garki branch of the NBA under our Medical and Health Law Committee. It is always a privilege given to our committee. We count it an awesome privilege to be convening these meetings every month. Since January, barring February and March, we have been consistent with bringing us one topical issues in medical law. This month, we will be discussing universal health coverage and health insurance, a practical approach to mitigating out-of-pocket expenses or payment for healthcare in Nigeria. What we have ensured that we do here is we don't do theory here. The personnel, we take so much pain, yes, and sacrifice to go all out to bring the best in any topic we are discussing. You may not understand. We take so much pain and sacrifice to bring the best on any topic we are discussing to come here. Those in the field, we are not just bringing lecturers, we are not just bringing professors of the subject without trying to denigrate or downplay their knowledge or wealth of experience. What we do is we bring field experts, those who deal with the subject matter on daily basis. So that at the end of the day, what we expect is that after this webinar, like today we are discussing health insurance and universal health coverage, our objective is that at the end of today's webinar, you will take action. If you have not enrolled in a health insurance scheme, you get one for yourself and for your family members. For those who have been consistent, we have discussed issues in fact, last month, we discussed forensic medical examination, investigation, looking at DNA and autopsy. And as usual, we brought experts in the field. We have discussed issues on surrogacy. We have discussed on compulsory treatments and care of gifting. We did that in 2023. The Victims of Gunshots Act. We have also discussed on the emergency treatment and the law, that's section 20 of the National Health Act. We have discussed on strengthening healthcare policy. We have done a lot. Imagine January till now. So we have done a lot. And today is not an exception. Today is very unique in the sense that we have two veterans on this subject matter to discuss. Dr. Ifeanyi Nsofo has been my oga since Adam was created in this area of medical law practice, and there is no how we can discuss universal health coverage and Dr. Ifeanyi will be missing. Whether he's in Nigeria or in America, it is immaterial. It is just that he is an authority in this field, and that is why we had to bring him on board. Same goes to Dr. Uche Welike. I call him Dede. So Dr. Uche is currently serving as the executive chairman, the executive secretary and CEO of Imo State Health Insurance Agency. Now, that office alone tells you his capacity. But for him, it is not about position. It is about doing the work. I would like you all to just go on Facebook, type Imo State Health Insurance Agency, or type Dr. Uche Welike. Just Uche, his name on Facebook is Uche Welike. Just type Uche Welike, scroll through his pages and see what he and his team have been doing in Imo State to ensure that health insurance gets to the rural people. I am aware 2-3 months ago when they were doing enrollments, you needed to see the turn up. You needed to see the community mobilization. You needed to see people leaving cities, going to the village to ensure that their people are enrolled, including legislators. That is how much I follow their activity. Yesterday, they are about commission doing project inspection, and it also relates to healthcare. I watched that video. I saw him. I saw the commissioner for health and other personnel along with the governor. So I am following what is happening in Imo State as far as health insurance is concerned. Now, this afternoon, because of his engagements, one of his technical aides is here. That's Mr. Tochukwu. And this webinar, we couldn't have secured Dr. Uche's attendance without the person of Mr. Tochukwu. So, gentlemen, I said this to lay a foundation for you to be open-minded. I want to see that, believe that you have your notes beside you, and while the webinar is ongoing, be taking decision on what action you are going to take in as it relates to health insurance. So, gentlemen, on behalf of the Garki branch, and particularly the membership of the Medical and Health Law Committee, I welcome you all to today's webinar as we sit back and listen to the best hands in this field. I humbly hand over to the moderator. Thank you very much.
Thank you very much, our convener, Mr. Beniza Iguatu. Thank you for your efforts. Thank you for your unwavering tenacity in ensuring our continuous legal education continues, and going all the way to reach out and ensure that we have this monthly educative and impactful webinar. Thank you very much, sir. So we are going to kickstart. I'm going to call on our two speakers, Dr. Ifeanyi Nsofo and representative of Dr. Ewelike, Mr. Tochukwu Ibe, pardon me, to give your introductory remarks, 3 minutes at best. Then I will now come back to Dr. Nsofo for his session. Then after which we're going to take we're going to take question and answer for him. Then when his session is done, we'll now come back to Mr. Tochukwu Ibe. So earlier I asked our participants to let us know where they are joining us from in the comment section. I can see our colleague from Nsuka branch, and I also saw a colleague from Unity Bar. You are all welcome. Even if you are not a colleague, so to say, but you are a participant, you can always let us know where you are joining us from. So thank you very much. So Dr. Rufai Yusufu is a health policy leader, public speaker, and co-founder of the Africa Behavioral Science Network. He advocates for universal health coverage and health insurance equity, and is presently based in United States of America. You're welcome, sir. And Dr. Uchenna Ewelike is an Imo State-born senior public health physician and health economist. He's the executive secretary of the Imo State Health Insurance Agency, the agency of government responsible for financial risk protection in Imo State. He has been instrumental in driving the universal health coverage initiatives in Imo State. If you listen to what our convener just said, you can fill in the gaps. And he's a health economist with global repute and a member of the Global Joint Learning Network for Universal Health Coverage, where he has participated and led discussions on health insurance, medical audit in South Korea, Bahrain, and Kenya. And he's also the author of the first indigenous health financial book in Nigeria, Basics of Health, titled Basics of Health Financing in a Developing Economy. That's why I said earlier that it's a star-studded session. So your opening remarks, Dr. Ifeanyi Yusufu, very briefly, then we'll come back.
Okay, thank you so much. Well, to be honest, I don't think I have any opening remarks per se. The only thing I need to reiterate is just to thank Ebenezer. He's been quite consistent with these opportunities for to share knowledge with the legal community in Nigeria, and yeah, thank you for that. And once Tochukwu gives his introductory remark, I'll just come back and make my presentation and take questions or comments that people have. Thank you. Over to you, Olatunji.
Okay, thank you very much, Doctor. Thank you very much. Thank you for the very brief remarks. So, Mr. Tochukwu Ibe, please. Thank you very much for joining us from Ilorin, Muhammad Raji. Thank you for joining us from Lagos branch. Maduka Zioma. Yeah, even though I earlier mentioned that this is not for the CPD point, so there is no need to drop your SCN. At the right time, you will get the headliner on how to proceed about that. This is just an introductory session just to tell us where you are joining from. We don't need your SCN at this point. Thank you very much. Is Mr. Tochukwu Ibe? Okay, we'll come back to him. So Dr. Nsofa, back to you. You can go ahead with your presentation, sir. Thank you.
All right, thank you so much, Olatunji. Okay, so I think for now, I'll just go off camera. When we get to the Q&A, I'll put it right back on. So when Beneza approached me for this session today, I knew it was going to be a short one, and I wanted it to also be, packed with so much information, and hopefully information that most people here are not aware of, so that ultimately we can get, everybody here as an advocate for universal health coverage, as well as, and by extension, health insurance. And so I decided to title my presentation as Redirecting Our Naira, How Nigerians Should Invest in Health Insurance. And hopefully by the time I'm done, you would see why I decided, to use this title. I won't waste so much time on this. Just, a bit about myself. I think for me, the most important thing is that I'm a public health physician and an advocate for universal health coverage, health insurance, and health equity, ultimately, because I think that health is really the most important thing that we should all strive for. Why do I say that? In 2018, I gave my first TEDx talk at TEDx Ogui Road. And the title of that talk was, "Without Health, We Have Nothing." And, interestingly, 2 years after I gave this talk, or less than 2 years, COVID-19 happened. And I think COVID-19 was an eye-opener to everyone that indeed, without health, we have nothing. Because an infectious disease outbreak that started thousands of miles from Nigeria grounded the global economy, killed more than 6 million people. So many people were sick. So many people are still living with complications of COVID-19. Yeah, so without health, we have nothing. I think if you do not take for me, one of the major takeaways I hope people will go with today is that without health, we have nothing. When you fall sick, whatever the illness is, you would realize why without health, we have nothing. You may not be able to go to work, you will not earn, you become a burden to yourself. You may need a caregiver, family member who will be tied down as a result. Yeah, so I don't think we can really overemphasize the fact that without health, we have nothing. So what is universal health coverage? So for me, the way I want to approach the definition of universal health coverage is through two lenses. One is the equity lens, then the other one is, through the lens of a spectrum that is defined by the World Health Organization. So first of all, the equity lens. I mean, the definition of universal health coverage, as simple as possible, is everyone having access to the healthcare they need, but without suffering financial hardship. And you know that, to be honest, every one of us is just one sickness away from financial hardship. There are some illnesses you have, by the time you finish treating it, you have to borrow, sell your houses, sell your cars, sell land in order to pay for the healthcare. So for me, universal health coverage is this concept that everybody deserves access to healthcare that they need at any particular time and not suffering the financial hardship. So for me, that is the equity lens. Equity, everybody has access to it. Now, but interestingly, when most people talk about universal health coverage, they only talk about the equity lens and they've hardly mentioned spectrum. And the spectrum is defined by the World Health Organization, because the World Health Organization says that universal health coverage is actually a spectrum of care. Because, most times when we talk about healthcare, people only focus on treatment, right? So you're sick, you go to the hospital, you're seen by a doctor or any other colleague, a pharmacist, a nurse, you're given some medication, you take it and you get better. Most people's view of healthcare is narrowed down to treatment, which is number 3. But I like the way that the World Health Organization expands universal health coverage. There is a spectrum. So there is health promotion, there's prevention of illnesses, there's treatment, there's rehabilitation, because sometimes, depending on what kind of illness that you have, it requires some kind of rehabilitation. There's also palliative care. Palliative care is for people who have very chronic illnesses that what we're really trying to do, they may not be able to recover fully. So ultimately, we're giving them palliative care, especially those kind of illnesses that are end of life kind of illnesses. Let's say somebody in their 80s, has had this serious stroke and the person will not recover fully. So provide some palliative care. Rehabilitation, let's say you have an accident, you broke your leg. After the surgery and everything, you recover, but you need some kind of rehabilitation, physiotherapy in order for you to be able to work properly. Treatment, of course, we've talked about. Prevention, things like vaccination, things like, ensuring that people have access to clean water, because if they have access to clean water, they will not, have some illnesses that people who don't have access to clean water are exposed to. Health promotion is, telling people that, look, for you, these are the kind of things you need to do in order to ensure that you don't fall sick. So I think it's very important that when we're talking about universal health coverage, we don't only focus on the equity side. Let's look at the spectrum. It's a spectrum of care. And for me, as a public health physician who is interested in preventing illnesses, this the spectrum side of things really appeals to me, because when people don't fall sick, I'm happy, right? And the two parts of the spectrum that will make people not fall sick is health promotion and prevention, right? So I think I've made my case here, but hopefully by the time we go to Q&A, I'll be able to answer questions that you may have. And when you talk about healthcare as a whole, the bedrock of healthcare is primary healthcare. To the extent that in 1978, or 79, close to 45 years ago, the WHO international partners gathered people in Alma Ata, and they came up with the Alma Ata Declaration that primary health care is the bedrock of care. And primary health care is the one that is closest to you, is easy to reach, is affordable. We're going back to cost again. And so, for instance, and the interesting thing is that if you look at the components of primary health care, you'd realize that there's really, and because Nigeria's healthcare system, to a large extent, at least before foreign aid started dwindling, a large part of it was driven by donors, and you would think that what donors were doing was rocket science. No. If you look at the components of primary healthcare, it virtually covers any project that donors have run in the country. But the question we need to ask ourselves, and I'm happy that lawyers are here, is when you talk about primary healthcare, that healthcare that is closest to you in Nigeria, whose responsibility is it? And our constitution, defines health, or rather put healthcare in the concurrent list, which means that the different arms of levels of government have their core responsibilities as far as healthcare is concerned. The federal government is in charge of policy, setting a policy direction for the country, coming up with all sorts of policies that states can adopt. The states are in charge of secondary care, so like general hospitals. Federal government in charge of teaching hospitals, federal medical centers, federal specialist hospitals. Those are the core responsibilities of federal government. State government, secondary care, which is usually delivered through general hospital, cottage hospitals. But primary healthcare centers, which is where ideally the most important part of healthcare is delivered, is the core responsibility of local government areas. So the question we also now need to ask ourselves is, how many local government areas are functional in Nigeria? How many of them are delivering primary health care? How many primary health care centers are functional in Nigeria? So that if in my village, for instance, I'm from Anambra State, in my village, if the healthcare center in my village is not functional, it is not Tinubu that we're going to go and drag. It is not Soludo that we should drag. We need to drag whoever it is who is my local government chairperson. Why? Because based on the law, based on our constitution, it is the responsibility of that person. So you begin to now understand why, if you don't have a situation where state governments really ensure that local government councils work, then you would realize that most people will not have access to primary health care, which is the bedrock, which is the care that should be closest to the people. And another thing I want us to consider when we're talking about universal health coverage is social determinants of health. So social determinants of health are those non-medical things in our lives that affect how healthy that we are. So for instance, eating healthy, good nutrition, having access to water and sanitation, even education, ensuring that kids are in school, climate change, those are social determinants of health. And I want to use nutrition as an example. And if you go back to the WHO definition of universal health coverage, the part about spectrum of care, adequate nutrition, for instance, will fall under prevention. And one thing again I want us to focus on in this presentation is that we need to look at what are the things that are killing our people the most. And also we need to follow the money. Because if you know where Nigerians are spending money as far as healthcare is concerned, then you know how to, advocate to them to redirect that money they are spending, or in other spaces for health insurance ultimately. So, following data, if you look globally, mostly in low, middle, and middle income countries like Nigeria and other countries across the African continent, up to 50% of the causes of under 5 deaths, in other words, those things that cause the deaths of children before they reach 5 years of age, up to 50% of those causes are linked to malnutrition. So what that tells you is that if you need to stop or reduce the number of children that die before their 5th birthday, you need to ensure that children eat nutritious food. Children need to eat nutritiously. Their mothers need to eat nutritiously. Children after they are born need to be exclusively breastfed, right? Before you start introducing other things after 6 months, for 6 months. So I hope you're beginning to see how the spectrum of care really matters. And one thing I know that health insurance agencies as well as HMOs are beginning to do is when you buy a health plan, a core part of the health plan is preventive care. Because ultimately, if they can prevent you from falling sick, it is good for you, one, but it's also good for them. It's good for their bottom line. That means they're going to make more money. But ultimately, it's good for you because remember what I said, my TEDx talk, without health, we have nothing. I hope you're making the connection. Let's even use water. If you go across most local, villages in Nigeria, you can count how many villages where you go to and people have access to clean water. And that's why you have in those communities, children, for instance, when children have to go to all sorts of infected streams to fetch water, they come down with all sorts of infectious diseases as a result. Should we even talk about sanitation? I think it's very clear for most people how poor sanitation is linked to poor healthcare. Yeah, so primary healthcare, which is the most important care people should have, social determinants of health, these are non-medical issues, but they have huge impact on our health. And I think that in today's world, you cannot talk about healthcare without talking about a social determinant of health like climate change, because we know that it's causing huge issues as far as, say, agriculture is concerned. And if you trace it back from agriculture, it takes you back to poor nutrition. When we cannot feed ourselves, we're thrown to the challenges of, poor healthcare, especially affecting children and women. So, one other thing I said was we need to follow the money. Now, there's this thing called national health accounts that the WHO, the Federal Ministry of Health in different countries, supported by WHO and different partners, usually do it every 5 years, ideally. But the last one that was done in Nigeria was done in 2016 and published in 2018. What the National Health Account does is to look at how much that the total health expenditure in the country and say, who pays for healthcare? What are the different components? If you segment the different stakeholders, how much do they pay for healthcare? And interestingly, this last national health account that was done in Nigeria, as at that time, as at 2016, the estimated total health expenditure for the country was $10 billion. The exchange rate of then, not now. I'm sure if you did it now, it would probably be much lower than $10 billion. But let's focus on this because we're using a 2018 data. The estimated total health expenditure for Nigeria was $10 billion. Now look at the interesting thing. $7.7 billion out of that $10 billion was out of pocket expenditure, which means that 77% of total health expenditure in Nigeria is out of pocket. People pay for healthcare when they fall sick, right? And I have this chart. So if you look at this chart, the first bar is the total health expenditure, $10 billion. The second one is out-of-pocket expenditure, $7.7 billion. Now, look at how much donors give us or gave us as at that time, $1.1 billion. If you combine all the money that donors gave Nigeria, it was $1.5 billion for healthcare specifically. Now, what does that tell you? It tells you that what Nigerians spend on healthcare is 7 times what donors give us. So you begin to wonder, over these years, why have we really been so much bothered about how much donors were bringing to the table, when Nigerians already spend 7 times that amount out of pocket expenditure? But unfortunately, because of the way they spend that money, they don't get quality healthcare. And if you combine all the money by governments, federal, state, and local councils, it came down to $1.4 billion. Now look at another part of it. If you look at that $7.7 billion that was out of pocket expenditure, $2.6 billion out of that amount was spent in pharmacies and chemists. Let me allow that sink in a bit. So what Nigerians spend going to buy medicine in pharmacies and chemists was more than 2 times what international donors gave us. And this is why, I chose the title for my presentation. Nigerians, we need to redirect our naira. We're not even asking you to pay more. We're saying that money that you're spending to go and treat yourself in pharmacies and chemists, use it to buy health insurance. So you can imagine if we can advocate and convince more Nigerians to rechannel that high out-of-pocket expenditure towards health insurance. You can imagine how, the kind of huge impact that would have. And allow me to dream a bit. Imagine if we're able to get Nigerians to spend $2.6 billion for health insurance. Imagine the impact that would have, on our healthcare sector. So, key takeaways from this slide. As of 2018, total health expenditure in Nigeria was $10 billion based on the national health accounts. $7.7 billion, which was 77% of that amount, was spent as out of pocket, what people pay when they fall sick. $1.1 billion was by donors, $1.4 billion federal, state, and local councils combined. But for me, the one that really tickles my fancy is $2.6 billion that Nigerians spend at pharmacies and chemists. So what did I do? Because this was something, after I saw this national health account as at that 2018, the thing really blew my mind, because I was like, and I mean, you need to understand, I'm an Igbo man, by extension, I'm a businessman. When I see money, I begin to make all sorts of calculations. So I wrote a piece for Devex. And that piece is, it's time to channel household expenditures into health insurance in Nigeria. So we need to, and I'm happy that, the Imo State Health Insurance Agency is represented here to begin to, hear from what they are doing and how they are engaging different stakeholders to ensure that our people have health insurance in the state. And I think one other thing I need to mention is that I think at this point in time now, every state in Nigeria has a state health insurance agency. And those state health insurance agencies in each state, they are backed by law. And health insurance is mandatory, which means that the state governments can actually enforce people buying health insurance for themselves, because it is good for everybody, not just for the individuals, but for the state. If people are able to buy health insurance, the state will focus on other things, instead of spending so much and yet on healthcare, and yet very few people have access to quality healthcare. So my previous slide was to make a case for we need to really channel that money we're spending going to chemists and pharmacies. And interestingly, while I was still in Nigeria, I had gone to one of the pharmacies that was close to me to buy some. I think I went to buy, was it ibuprofen, just something for pain. And as I walked in, a woman was also walking in, and she was shouting, "Doctor, doctor, doctor." I thought she was talking to me. So I looked at her. Obviously, she was looking past me. She was addressing the guy selling the medicine as the doctor. So when we follow the money, we would realize that pharmacists are really very, very influential when it comes to healthcare in Nigeria. And I hope that we are going to involve pharmacists more in healthcare delivery in Nigeria, because our people trust them, our people respect them, our people take money to spend in those chemists and pharmacies. So for me, another major takeaway is how do we convince people to say, we're not saying they should pay more. To be honest, I don't know, I would like to hear how much that the monthly premium or the annual premium for the Imo State Health Insurance Scheme. But I know that for most states, it's probably somewhere between 40 to 50,000 naira a year. And when you say this, people say, it's too much money. But by the time you have just one illness, you will spend more than that treating yourself. Even if you went to the pharmacy to be buying drugs every month, at the end of the year, you would have spent much more than that. And it's also very good to manage expectations. When we're talking about health insurance, we're not talking about if you buy health insurance, all your health needs are going to be solved. No, but most of them will be solved. But most importantly, because once you buy health insurance, you have regular contact with the health system. That spectrum of care that I mentioned, health promotion, prevention, treatment, rehabilitation, and palliative care, you have access to those things so that ultimately you may not even, fall sick as often as you were before you buy health insurance. So this Christmas period, for those of us here, if you want to give any of your family member Christmas gift, buy them health insurance. If you can't buy from your state, there are private health insurance companies, HMOs, that you can buy health insurance from. One that I like very much is Reliance HMO, and even Wella Health, that I've worked with Wella Health, and they use community pharmacies, to help people get micro health insurance. And another thing I want to talk about, I just have like 2 more slides to end, is okay. Remember what I said initially, that let's follow what it is that kill our people the most, because we know that if we address those issues, then fewer people will die as we begin to improve our healthcare system. But one other thing I said was that we need to follow the money. And this was another one that really but when I found out this, I was like, really? As at 2023, Africans in the diaspora remitted, back to their different countries, $100 billion. Africans in the diaspora. Out of that $100 billion, Nigerians in the diaspora remitted $20 billion to Nigeria in 2023. In fact, by this year, by the time we get 2024 data, I'm sure it will probably be much more than $20 billion. Guess what? This amount is more than our national budget. So what does this tell you? This tells you that Nigerians in the diaspora are sending so much money back home. But the question is that this money that Nigerians send back home, what is it used for? They are used for different. So if I send money to my brother or my sister, they use it for whatever it is, whatever need that they have. And because of the way that we approach health, most of the time, people don't really spend this for healthcare. Or let me be very specific, they don't spend it to buy health insurance. So what did I do? Again, I wrote a piece for DevEx in 2019. And what I said was that remittances as the universal health coverage game changer. And at that point, I also tried to dream, because I asked myself, so if Nigerians in the diaspora remitted $20 billion back to the country for 1 year, what if we had a system where 1% of that money was somehow rechanneled towards health insurance. So what I was saying in essence is that out of every $100 that you send, what if $1 is set aside for health insurance? That was, that was the way I dreamed about it. And I was like, what if the government built confidence with Nigerians in the diaspora and we set up a mechanism for that? So if you're sending money back home, you can say, I'm sending $100, $10 should go for health insurance, and you pay it into a particular fund, or you channel it through any of the health insurance agencies, even state health insurance agencies now, or you go directly to HMOs and buy health insurance for your people. And I'm beginning to now find out that a number of HMOs in Nigeria are beginning to have, you know, a particular kind of health plan for people in the diaspora to buy health insurance for their families in Nigeria. And I hope that, in fact, even 2 years, was it last year? I know that the central bank also set up a diaspora account where Nigerians in the diaspora can pay that, open an account and put money there directly. Imagine if we're able to work out something where that money, depending on what state you're from, let's say when people remit money back, they say, okay, I'm from Anambra, the different states, you know what state you're coming from, and we say 1% of all the money that we get, we're going to, okay, let's use Imo State, for example, because Imo State is ably represented here. Let's say after all the money is remitted back to the country, we say, okay, for Imo State, we're going to take 1% of everybody from Imo that remitted this money and give it to the Imo State Health Insurance Agency to pay for health insurance for the family members of those people, or even for the poorest people who ordinarily, because of the economic situation now, won't be able to buy health insurance for themselves. So what am I saying? If we follow the money, remittances by Nigerians in the diaspora is a huge opportunity for us to grow our health insurance pool. Yeah, okay. So I will stop, and I hope you have questions, comments, or if you want me to clarify anything, that's fine. Let me stop sharing.
Thank you very much, Dr. Mustafa. That was an insightful session. Thank you very much for your effort, your inspiration. Pretty much certain a lot has gone into the research and your contributions. Thank you very much. I'm sorry, my apologies to Mr. Tochukwu Ibe. I realized that your mic was mute. That was why you couldn't give us your remarks earlier, but we'll still take your remarks after the question and answer for Dr. Unsofo. So please, if you have questions, you can drop them in the chat box. We can do that within the next 1 or 2 minutes. I also have 1 or 2 questions myself, Dr. Unsofo, so well, I can wait for while that is ongoing. And earlier, I noticed some of our colleagues joined from Ikeru branch, Fatima Kikelomo, Daniel Ugu joined from Kaduna branch, and Benga Jai joined from Ikeja branch. You are all welcome. Like I said earlier, please, there's no need to drop your SCN in the chat box. Don't worry about the points, that will be taken care of at the right time. Yeah, thank you very much. Yeah, so Doctor, while we're waiting for questions, and I also want Mr. Ibe to take note of this. One that I'm very aware of, one of the issues we are having is issue of advocacy. Most persons are not aware of what is even called insurance scheme. I myself, I know how many times I've had to enlighten folks on how to, with the reason why they need to. And secondly is the issue of pharmacy and chemists. Thank God that it came up, because sometimes when you're on scheme, even HMO providers complain when you have to, sometimes they'll tell you, oh, it's just paracetamol, you can get paracetamol yourself. Why do you have to go and get that on the scheme? But if you're on the scheme, you're on the scheme. And then thirdly, Sometimes some of these schemes are not easily accessible to individuals. Most times providers prefer it to be corporate. And most times what you get is just individuals, one or two. So how do we bridge that gap? I know generally it's still a baby steps in Nigeria, but how do we bridge this gap? I think we have one or two questions, then I can read that. So maybe before you respond.
Okay. Okay. Yeah, so again, thanks for those questions. So I think in terms of advocacy, I totally agree with you. Most people do not know, and when they don't know, they don't act. Private health insurance companies are much more interested in, say, reaching out to corporate organizations because they have numbers there they can easily get. And this is why I think that state health insurance agencies are really very important because part of some in 20 what I think was in 2019 I supported the Niger State Contributory Health Scheme to develop their communication strategy. I know that part of their own law, uh, has an equity fund where wealthy individuals from the state can put money so that government can cover people who don't have access to health insurance. But I think most importantly is that if state health insurance agencies really take the battle to the people, take the information directly to the people, um, working with the different leadership structures that we have in the country, whether it's traditional, cultural, religious, especially religious, and I think that is where the battle would happen. Years ago, when I was with Nigeria Health Watch, we were doing a project on universal health coverage for Christian Aid. And one of the things that we did was to also gather religious leaders or people who are in different religious organizations who were working towards setting up health insurance scheme. As at that time, I don't know if it's still functional now, but as at that time, this was 2019, 2020. As at that time, EQUA, which has probably close to 6 to 10 million members across Nigeria, was actually setting up their own health insurance agency for their members. For one of my colleagues then, who is a professor at the University of Ilorin, one of my colleagues' father, who was a professor at the University of Ilorin, was the one leading that, initiative to set up health insurance for the people. So we need to really diversify information, the way we put out information. State government has all the channels, that they can use, whether it's TV, whether it's radio, and if, again, focusing on Imo State because its culture is similar from where I come from in Anambra, focusing on town unions, focusing on age grades, talking to religious leaders, why, they can be mouthpiece for advocating to our people to buy health insurance. But the important thing is that making a case so that people see the need for it. Because unfortunately, most people in Nigeria will tell you that it's not my portion to fall sick. It's so bad that even when people are sick, you ask them, how are you? Instead of them telling you, okay, I'm not feeling too fine, they will say they are strong because of that strong religious influence, which is why I think that religious leaders have to have a part to play here. But we also need to really work with social media. Because across Nigeria, on Facebook, for instance, close to 52 million Nigerians are on Facebook. That's a very important platform to keep putting out information. And we cannot relent. It's not like when we do it once and we expect that people will change behaviors. It will take some time for different people, hearing the same information to say, okay, I see the need for it. And I also think, I remember while I was also in Abuja, once I took a taxi from Lobito Crescent in Wuse to going to my office then in Tiwad and Jima Foundation. And the driver, was talking on the phone and somebody had called him and he was responding to the person. He said his wife just delivered, had a set of twins, and they were asking him to bring 70,000. And I said to myself, if this guy had health insurance before the wife got pregnant, he will not be paying for that delivery, for instance. And for a taxi driver not to be know, or maybe he knew but not seeing the need for it, really shows us that we need to consistently engage. we need to use all the channels. And I think that because private health insurance companies are really more profit-oriented, government has a huge role to play here through state health insurance agencies, because that's their core responsibility. Yeah, of, to mobilize our people and get them to buy health insurance. And I think one other way is also if we get people who have more disposable income, right? My colleague from medical school, Dr. Francis, who works with WHO, I know in his village, he's also from Imo State, by the way. He has a foundation that pays for health insurance for people who cannot afford it. So we need to, really, really fire from all cylinders, to make sure that we convince our people. Talking about pharmacies and chemists. So if you follow the money, our people go to those places to buy medication. So we need to find a way of involving them. What Walla Health does is using community pharmacies to get people to buy health insurance, micro insurance that would cover, some basic services for, for people in different localities. And Walla Health, they work with more than 2,500 community pharmacies across Nigeria. So, it's a very huge, they're a small health tech company, but they've processed more than 1 billion naira, through those pharmacies for micro health insurance for people. And in fact, there's a project I'm leading in Nigeria now on HPV vaccination. We're using social media and community pharmacies to inform people about HPV so that they can take their daughters to the primary health center to get vaccinated. So we can't relent, but I also appreciate the fact that in different parts of the country, different things may work. I grew up in Kano State, northern Nigeria. I know that in northern Nigeria, radio is quite powerful. So radio would be a very good medium to get a lot more people to know. But it needs to be consistent and relentless, hopefully to get, more people to buy health insurance. Over.
Thank you very much, Doctor, again, for doing a wonderful justice to the questions. So there are two big questions. I understand that you might need to run along, but before you go, I think you've answered this question of the role of religion in, because you talked about Equa Church. So I think in a way, you handled that question.
Sorry for cutting in. So the two questions, those are the last two. Yeah. What is the place of occupational? I will take both before I go. What is the place of occupational health and safety in the national health insurance coverage and policy in Nigeria? Okay, can I just ask Emmanuel to explain better briefly what he means by the place of occupational health and safety? Is it covering workplace related injuries and stuff like that? Emmanuel, Ejim. Emmanuel Ejim, can you just, is your question about whether national health insurance policy covers workplace related injuries?
Well, Emmanuel, you can raise your hand. Let's unmute you so that we save time. Emmanuel, kindly raise your hand so that we unmute you.
Okay. So
he's not.
Okay, fine. So let me, because since he's talking about occupational health and safety, let me assume that's what the question is about. So the good thing, like I said, about health insurance, that when you buy health insurance, usually there are different plans. There are different health plans, each particular plan costs, what it covers. So I think as you're buying health insurance, you need to be aware of that. What does it cover? It to be properly documented there. Okay, he says that's what he meant. So look at what your health insurance plan that you're trying to buy, what it covers. But talking about occupational health and safety, so let's assume that you're working in a place where, let's say, a butcher in the market, and as he's cutting meat, he slices his finger or something like that. When that person is taken to the hospital, I do not see how that particular trauma that the person went through would not be covered, because it's almost like somebody saying that somebody has an accident. But of course, if you look at each plan, what it covers, if there are co-pays, depending on what kind of service. Because, for instance, they will say they can cover surgery up to, say, 500,000 naira. If it's more than that, you have to pay the difference. If it's not up to that, they would cover it. So I think it's important to look at health plan, what is the cost, what are they covering? Because like I said initially, the fact that you're buying health insurance doesn't mean that it will take care of all your health needs, but it will take care of most of them. Having said that, look at the plan, what it covers, so that, for instance, if one plan is 50,000 a year, and the next plan is 70,000, you see that the 20,000 difference gives you a lot more benefits. It's cost effective for you to get the 70,000, depending on, again, talking about occupation, what it is that you do, and the likelihood that what the 70,000 naira one covers, includes the things that you may be exposed to. Amaka says, I join in labor. There is this challenge of when one moves from one state to another, the process of assessing healthcare insurance has lots of bottlenecks. And at the end of the day, you see that one is paying out of pocket for these healthcare services. I think these insurances shouldn't be limited to one state of registration or residence. I don't know if there's a policy control on this sort of challenge. So again, we need to differentiate between state health insurance agency. So if you're in Anambra and you buy from the Anambra State Health Insurance Agency, you can't use it in Imo State because they are two different, states. They have two different domains. However, for most of private health insurance, if you want to buy, say, from Reliance HMO, which is one that I know very well, if you go to their website, for instance, and you reach out to them, they usually will send you the list of the hospitals that they work with in every state in Nigeria. So if you're buying from a private health insurance provider, it doesn't matter what state you're in, as long as they have the hospitals within that state, you will go there and benefit from the health insurance, from your health insurance plan. And when I was in Nigeria, I did a lot of travel across different states. It was something that made me confident traveling because I knew that the HMO we were working with, had a list. Every HMO in Nigeria, private HMO, has a list of hospitals that they work with in all the 36 states plus Abuja. So if you're somebody whose work takes you around the country, maybe you'd be more inclined to buy a HMO plan from a private provider as opposed to the state, because you know that when you leave that state and go to another state, what you've paid for in the previous state will not. Okay, you say it's private health insurance. I mean, to me, that's really shocking, except if it has changed within the past 2 years, which I don't think so. Because, and again, I don't know, it's also possible that, I don't know if based on, again, that the National Health Insurance Agency Act was signed by Buhari before he left. I don't know if there are HMOs now that have, like regional reach, so that if you're not in one region, you can, I don't know. But I think that these are the kind of questions you need to really ask the HMO before you commit. Because once you've committed your funds, you can't say otherwise. So I think for me, in summary to the question that you asked, Amaka, is that when you're buying your health insurance, ask for the different plans, what they cover, and what is their coverage in terms of states, so that you're very sure. But I think I can stake my neck that private health insurance companies, they have hospitals across Nigeria, or else it won't be good business for them if it's really limited to one state. But who knows? If you ask that question directly, so you're very, very sure before you commit your finances to any of them.
Thank you very much, Dr. Sofo. Sorry, we don't have a good medal at the moment. We have done the Medal of Honor for you. But thank you very much. That's been insightful. Just a moment before you go, I think if I would do a little recap, you are advocating more for state-owned facilities for health insurance as against private-owned, that it will be better and accessible for the citizens and so to say, average persons. And then to answer Amaka's questions further is that private-owned insurance providers, they are more accessible across all the states. And I think I can also attest to that. So it depends on the provider she had reference with, but most often than not, it's easily accessible and you can change. All you need to present is your number, if I'm correct, and they will register you in the new hospital. Yeah, but just that you are advocating more for state-owned, which I support, and I believe it will go a long way to benefit the persons. I think, well, okay, maybe federal is the NHIS scheme. That should be under the federal, but I think we can do more if we have the state-owned. But I don't think I've really heard about the state-owned, more of the state-owned, or maybe because I'm in Abuja, but I've not really
Yeah,
heard.
even Abuja has the federal FCT Health
Oh,
Insurance Agency.
okay. Okay, but above all, thank you very much, sir.
But let
Thank
me
you very
say,
much.
sorry, Olatunji, just to
Yeah.
be sure, let me just say three things. One, anybody here who doesn't have health insurance, please buy health insurance. It's very cost effective for you. Secondly, if you want to give anybody Christmas gift this year, buy health insurance for them. In your state, go through them and buy health
Yeah,
insurance,
health
and
insurance.
ultimately, we'll be healthier for it, and and spend less. It's definitely
Yes.
much more cost effective. Yeah. Over.
Yes. Thank you very much. Let me just support your statement before you leave. So when one of my children was birthed, 1 naira I didn't pay because it was on insurance. 1 naira I didn't spend a dime, 50 kobo. Even up until immunization, 3 months, 4 months, 1 naira. And then you hear when patients say, oh, they paid so amounts, even for years. In some cases, the hospital will even keep them until they're able to make full payment. But if I'll just ask them, why did you go on insurance? It saves you the hassle. Even if you had to pay extra, it won't cost you much.
Yeah. Absolutely.
Thank you very much.
Awesome. All right. Thanks, guys. I'm signing up.
Go, doctor. Thank you, sir. Hey, yeah. Okay, no problem. Our second speaker should be able to take these questions when he comes on board. Mr. Moderator, kindly note the question by Ben Favor. He says, what's the actual difference between Federal Health Insurance Scheme cover, that's FHIS,
and SHIS?
Yes, please take note so that our second speaker, we attend to that question. Thank you. Over to you, sir.
We need to make Mr. Tochukwu Ibe a host so that he will be able to make his presentation.
Okay, he's not a co-host.
Mr. Tochukwu, you should be able to. Yes, thank you. You can talk now. I believe that's big. So on. Then use the function, use the convenant branch. Which is this proposed to use those policy.
not just US, but also and also I would like to thank the moderator, Mr. Latrish, for being able to take this space. This is program so far. Then the speaker I just relaxed. I also want to commend this wonderful presentation. They have already sparked conversation into also help to give me into our presentation. So, having said this, I would like to also make my own presentation. For hidden lands, crime, simple as really a very important agreements not just legacy, but this PhD approach. Yeah, because when the Amapa definition was made, USC has for all, and WHO also adopted the PhD approach for these member states. So I also led very wonderful foundation of that. So for me, for those of us who are health insurance, so I would also like to focus my presentation on how health insurance is not a very predictable and it's important in the city. And only few of us as well. So can you see my screen? So let's see if you can respond. I think I'll be it'll be fine to note experience. So I didn't get any response. Should we proceed?
Yes, sir, we can see the screen, but you may have to be a little bit more audible, sir, because we are straining our ears to hear you. Hello, Mr. Tochukwu. We can see your screen, sir. Just kindly be more audible, sir. Thank you.
Okay, so am I? Is it better now?
It's better. It's better. It's better, but I think it should be a function of network fluctuation because it's breaking.
Is it better now?
Yes, yes, it's better. It's better. Very okay, sir.
Yeah, so before I start, it's also important I also inform us that I am representing, speaking on behalf of my boss, Dr. Uchene Welike, who is the Executive Secretary of Imo State Health Insurance Agency, and he is also on the absent. Assistant. I'm the technical assistant to the Executive Secretary. So the first speaker has already laid the foundation on USA and the adoption of PAC as an approach by WHO for its member states. I think I will just go straight into health insurance and what the Imo State Health Insurance Agency, the strategy the agency has deployed so far to mitigate out-of-pocket payments for the residents of Imo State. So my presentation outline will be looking at have at least understand the concept of USC and challenges of out-of-pocket payments in Imo State by looking at the situation, running the situation analysis of Imo State before the operationalization of Imo State Insurance Agency. We also look at the role of the Health Insurance Agency, that is Imo State Insurance Agency, in mitigating these out-of-pocket payments. Then we also run through health financing and other programs of the agency, and most importantly, the agency's population coverage building blocks, because speaking about universal health coverage, population coverage is very key, and any reform process by the government on USC must always focus on population coverage. So we will look at what the Imo State Health Insurance Agency has done. So more of what I'll be presenting to you are really practical approach and not theories. These are strategies that we have adopted and we're able to cover at least appreciable number of the population, appreciable percentage of the population. Then we'll also quickly look at our success stories and interventions that were provided in these rural communities where access to healthcare services is actually a challenge. Then we'll look at challenges that are affecting or hindering USC in Imo States, and also our prospects. So that is my presentation. This is my outline. Then we'll move right into it. So the concept of USC, I think I'll just be speaking on the foundation that has already been laid by the previous speaker. Given that I am of health insurance background, so I'll be speaking towards APT. Why he focused on spectrum of health. So I'll also be speaking, I'll also be focusing on how we can make this, how we can make access to healthcare services very equitable for our people. So the concept or the idea of USC is to ensure that individuals receive the needed healthcare services, and when they do that, they don't suffer financial hardships or fall deeper into poverty because they have spent all they have just to take care of their health treatments. So, and these treatments we are talking about, or these services we are talking about, are also in line with the spectrum of health that the former speaker just highlighted, which is the promotive, preventive, curative, rehabilitative, and even the palliative care that he just mentioned. Then we also focus on how we can also promote equity by ensuring that those who fall within the low income group, those who will consider poor and vulnerable in the rural communities, can also be included in our population coverage. Then we also look at, under USC, the concept is also to strengthen the entire health system to enable sustainable assets. So basically, USC is the idea of someone, a common man in the streets, having access to quality healthcare services, regardless of their ability to pay or regardless of their socioeconomic status. So that is what USC aims to achieve. Then we will we'll look at the USC dimensions of coverage. So USC, there's this popular USC cube we talk about, right? USC focuses on cost coverage. So ensuring that people don't pay much or share when they access care. So when they are paying user charge or paying user fee, right, they don't have to spend so much in doing that. So it aims in terms of cost coverage, aims in dropping the financial burden. Not just dropping, also keeping people protected from the financial from the financial implication. Then we also look at the population coverage. So the USC cube has the height, which is your cost coverage, and it has the base, which is your population coverage. That is the number of persons who are enrolled or covered under health insurance in your states. But the target is usually 100%. Then the breadth of this USC cube talks about focuses on service coverage. So these people whose cost sharing is reduced and who are covered under this population, what type of services are they receiving? What is the scope of this service? What is the depth? So how robust is the benefit package? Does the benefit package comprise, is it holistic? Is it comprised of the promotive, preventive, curative, and rehabilitative care that has been identified by the WHO in terms of definition of health? So these are the three very so these are the three key USC cubes. So, but then we'll look at what we have in Imo State. As of 2018, WHO conducted a study in Imo State and came up with all these informations. So, but what is most striking on these studies is that Imo State has 92% out-of-pocket payments. So Imo State has 92% out-of-pocket payments, even though our literacy rates, according to the WHO study by 2018, is at 98.2. And when they also further did this study, they realized that there's also 74% willingness, ability for people to pay for health insurance. So meaning that regardless of the fact that our literacy rate is high, meaning that we understand what health insurance is all about and its benefits, but yet our out-of-pocket expenditure is very high, above the USC benchmark. So the USC benchmark is that a household's out-of-pocket expenditure on health shouldn't be more than 40% of their income. But you see, the total out-of-pocket expenditure on health, that is as a state, 92% of health expenditures are coming from people's pockets. So this is very regressive, and it's capable of forcing people further to poverty and hardship. But then it was the establishment of the Most Health Insurance Agency now became more like a product of this. This was produced, or what led to the establishment of the Imo State Health Insurance Agency, and not just the Imo Health Insurance Agency, other state health insurance agency across Nigeria. So this is where Imo State was without any viable health financing vehicle, just as the state health insurance scheme. So before the establishment of the agency, So already there were consequences of this 92% out-of-pocket expenses. So you realize that there was low demand creation at PSCs. People are not even aware of the PSCs that are close to them, not to talk about visiting them. They don't know the kind of things, the kind of services they render there. So they are not even interested in what happens in the PSCs in their, especially those who are living in very rural areas. And there's also low health facility utilization. So even those who are aware, who go to these facilities, don't also use them for very essential, to even get essential healthcare services. They don't actually use them as they're supposed to. There's no referral system. There's no linkage between primary healthcare centers, the primary healthcare workers in the localities, and the secondary providers, probably in the urban areas or even in the semi-urban areas, but those who have the capability to render very expanded healthcare services other than primary level. So there's no linkage. And what we usually see in the PSCs, all this I'm just explaining are things that we met in Imo State before we operationalize the programs of the agency. So almost 90%, when you go to these PSCs, what you get is out of stock. So they do not really have essential drugs and commodities in stock. And this is because there is no centralized health financing system that will even cover the poor and vulnerable populations in these rural communities. This also led to high maternal deaths and also the issue of poor infrastructure. So, but when a financial risk protection scheme such as the Imo State Social Agency was now brought on board through the law number 4, 2018, and was inaugurated to ensure that people have accessible and affordable and quality healthcare services in Imo State. So this law or this agency was established now with the goal to guarantee that health of Imolites, that is people living in Imo State, are guaranteed to sustain a productive society. So they had the mission and they had the goal and the mission and the vision. So I'll quickly run through all this so that we can get to the part where we deployed some practical strategies to mitigate our own out-of-pocket expenses in Imo State. So this is our strategic objective at the agency. One of them is to reduce the cost of needed healthcare services on residents through reduction of out-of-pocket expenditure. Another one is to ensure that value for money for health services rendered to beneficiaries through strategic health purchasing. So we don't just pay, we ensure that what we are paying, you are getting the services that you are supposed to get. And we also ensure that premium contribution and access health services are based on ability to pay and need respectively. So now there are 3 core functions of the agency in terms of health financing in Imo State. So one is resource mobilization. The agency pulls resources together. And when doing this, there are very key things that come in mind or we need to really factor in. Because they say that there is nothing actually free. There is no free health services. So even the ones we consider free are being paid for by someone. So that is why the saying goes, for everything that is consumed is provided, and anything that is provided is paid for. So how do we get the resources? How do we mobilize the money or the naira to purchase healthcare services for our population in Imo State to ensure that we attain USC? So while we plan on that, there are very key things that we need to consider, which is APT. So any process, any mechanism that we want to adopt, we have to ensure that it is equitable. That is, we are not just changing our poor and vulnerable population. So we have to focus on revenue raising options that do not put pressure on the low income groups in our community or in our states. So also consider the fiscal space of the government. Does the government have the room to fund their health system? And how far can they go without going bankrupt? How far can they go and still be able to carry out other functions or provide other social amenities? Then it's also important that we considered the microeconomic stability of the states. A state that is not economically stable, and you won't really be able to plan or get a very effective revenue raising option. Then another one is, so under this resource mobilization, the Imo State Insurance Agency was able to pool resources across different income groups, different population groups. Like we have people from the formal sector who are paying in money. We have people from the people in the informal sector who are in groups, unions, associations, who are also paying money for their own health, and even the tertiary institution students who are also covered under our program. These are even if currently now in Imo State, we also have state actors, politicians, philanthropists who are enrolling their people into health insurance as a way of showing care or palliative care for their people. So these are different ways that we have also strategized to be able to mobilize resources for health in Imo State. Then another function in health financing, which is risk pooling. So in our program, so far, we have the elderly, we have different risks, right? So we have people, we have the young, we have the old, we have the healthy, we have the sick. So, but the beauty of it is this creates a greater cross subsidy, right? So those who are sick, those who are healthy pay for those who are sick, and those who are rich pay for those who are poor. And the young also subsidize for the old. So, but whenever these resources come together, they are put inside one pool and it loses its name. So health insurance money does not bear anybody's name, does not bear name of any income group or any association. It's a very big pool mix. What is important is when anyone falls sick and requires healthcare services, the agency should be able to take money from that pool and pay for the person's health. Another thing that is also striking is strategic purchasing. So there are purchasing in healthcare services, but most of them are very passive, right? And they lead to wastages. But the agency has a way that they are also strategically purchasing healthcare services for their people in Imo State here. So while you define what to buy, which is your benefit package, from who to buy to which is the providers and how to buy. So how we have designed our how to buy is based on our own payment mechanism that we use in Imo State. And that has been very, very effective. We call it the Imo Diagnostic Rated Group, which is a modified form of fee-for-service. Those of us who have used NHIS will have sometime in their life heard about fee-for-service claims and all that. So, but we are using a very modified one, which we call the ideology, and I'll explain that further in this presentation. So the agency, to mitigate this out-of-pocket expenditure on Imo people, the agency designed, following this establishment, they designed 4 programs to capture different groups. So we have the Imo Care Insurance Program, which is designed to capture those in the informal sector, that's our market women and those who are not employed by the government. Also, we have the formal sector social insurance program, which is designed to cover our state civil servants, just like we have the NHIS that covers the federal civil servants. And we have the basic healthcare provision fund, which is a pro-vulnerable group that is a product of the National Health Act 2014, which allows for the surrendering of 1%, at least 1%, or dedication of 1% consolidated revenue of the Federal Republic of Nigeria to purchase healthcare services for those who are considered poor and vulnerable. And we also developed a program for our states, students of states owned universities in Imo State, which we call the Tertiary Social Health Insurance Program, TSHI. So these are the strategies that we embarked on. But talking about UHC, like I said earlier, UHC it focuses on key three things. One is population coverage, cost sharing, and services. So for population coverage, the Imo State Health Insurance Agency developed what we call the initial population coverage building blocks. So we needed a strategy on how we can achieve population coverage in Imo State. And we said the key beams in this strategy is political will and technical skills or technical capacity. So as there's a correlation there's a correlation between how well a health system will do with regards to political commitments. So first, you can't really successfully talk about the 100% population targets when you don't have the political commitments from the government. Because UHC focuses on public spending on health, not on individuals or donor funding. It focuses on intentional public spending. And the higher the public spending on health, the better the health system. So political will becomes a very key critical success factor and even technical capacity. So having technical commitment and not also having the having the political commitments and not also having the technical requirements or capacity or knowledge on how to implement these health financial risk prevention programs also becomes an issue. So, but the agency came up with these 4 building blocks. Why they developed the 4 programs? The Imo Care, the formal sector, the BACPF, and the TSHI. So the Imo Care is to cover the 85% population coverage of Imo State, which is in the formal sector, which is a very large pool. And the Imo Care also hopes to get a buy-in from the diaspora participation. That is our brothers in overseas, which currently we have one of the diaspora groups in Imo State. They call Mbise USA. Is a very big the diaspora group that is based in USA. They gather together, they raise funds to cover about 3,000 residents of from 3 local governments. So I have to say this, I have to highlight this because Dr. Ifeanyi Sofo also mentioned how the diaspora group can invest in the health of their loved ones here in the country. So we have such models already. We have people, our own brothers in overseas, in diaspora can come together, put their resources together and purchase healthcare services through the state health insurance scheme for their people here in Imo State. So we also develop adoption strategies where philanthropists can also adopt people into health insurance by paying for their premium. So we call it adoption. People can adopt 1,000 persons. We have seen instances where over 3,000 persons were adopted by philanthropists and well-to-do individuals. Then constituency programs, we have also modeled this Imo Care Health Insurance Package to now come in form of a constituency program for our political actors. So they do, as they are doing empowerment, as they are doing other constituency programs or projects in Imo State, they also leverage on the already existing health insurance scheme and enroll a good number of their constituents into health insurance. And it has yielded positive outcome. Yes. And we also have associations and cohesive cohorts, and organized private sectors. These are all under the IMOCare health insurance program that we modeled to cover the 85% population coverage. So what this means is that if we can achieve this 85% coverage, Imo State is, I think, about 5.4 million. So you should also, when you do the calculation, you know what it's 5% of that population coverage is all about. So we have the formal sector, which captures only just about 5% of the population, because this is the only population that are under the government employment. So the agency also targets, there are strategies under this formal sector that can also enable the agency achieve this 5% population, which is through payroll deductions, organized labor, buy-in, strong political will, and informed provider base. So far, the organized labor in Imo State, that is NLC Imo State chapter, they have also appreciated and shown confidence in the implementation of the health insurance program for the states and local government civil servants. I think they have been co-creating solutions and designs of how these programs run. So they are fully participating in this program in Imo State. And they have also, given that in Imo State, the government is paying for principal civil servants. So the government is taking care of the health insurance premium of principal civil servants. And the dependents are still outside this UAC coverage. So which the Labour and the Imo State governments are, they are working out a plan. I think they are looking to how they can now bring in the dependents of these principal civil servants into the coverage. Then the BACPF, which most of us already know, is an existing vehicle that helps to pool or give access to poor and vulnerable individuals in the rural communities. Its own population strategy is also 5%, and the funding so far has been sustained, and it has outlined implementation strategies or guidelines. It also has strong oversight and inspires strong community participation and engagement in the implementation. Another block here is the T-SHIP, which covers another 5% population. This one encourages sustained engagement with student unions, and it also improves the health systems in the university and ensures also strong referral mechanism. So these are the strategies that the agency hopes to, the agency develops to enable the agency achieve its total population coverage target. So going forward in these conversations, we will know how that panned out. Then for DemoCare is an affordable payment mechanism that covers benefits for informal sector population, example, the artisans, market unions, groups, cohorts, individuals. It is our own flagship as it targets 85% of human population. And we use clustered enrollment systems. So further in this conversation, I should be able to expose to us most of the strategies that the agency applied or employed that has yielded very good results and helped the agency to achieve great milestones so far. So the premium for this DemoCare is 15,000 naira per person per annum, and with 4 persons as minimum entry level. So what it means that you cannot come into this pool as an individual. But I think this policy has been adjusted, right? This policy was when the agency did not really have much persons in their pool. But now that we are able to do good numbers, people can come in now. I think this policy is a bit relaxed, but our premium is 15,000 naira per person per year. It's 4. The difference between the federal health insurance scheme and the state health insurance scheme. So there are a lot of difference both in premium distribution or premium contribution and waiting period. But when we get to that, I think we also cross the bridge. So what are the practical strategies did we employ to enable us to mitigate out-of-pocket expenditures in Imo State? So one of them, as displayed here, is that we enrolled different population cohorts, just like we did for Imo State workers. We also enrolled the pensioners, those who have retired, those who have worked for the government. Now the government is now taking care of their healthcare needs. We also ensure that our benefit package was comprehensive, it's very holistic and comprehensive. And we develop and design a homegrown provider payment system. We call it Imo Diagnosis Related Group. So this particular payment system is not the same with the fee for service that we hear or other people in other health insurance schemes use. So we develop an outcome-based, output-based performance-driven payment system that ensures value for money. So under our program, our healthcare services are actually managed in such that sometimes you don't get to hear the issues that you get other health insurance schemes talk about regarding HMO and claims management, because this particular payment system eliminated the use of HMO. So the most health insurance agencies do not really work with HMOs. We pay and manage our claims by ourselves. So providers render services and we pay them based on the output of that services that they have rendered. So another is also launch of the governors of Ozodema's 2.7 million Imo Care enrollment drive to cover Imo residents. So this is another practical strategy that we have also embarked on to reduce out-of-pocket expenditures in the Imo State, which is ensuring that almost 50% of the population is additional 50% of population is covered under the health insurance scheme. Then we also, like I mentioned in the beginning, adoption strategies. We also have local government chairmen, political actors, and philanthropists adopting good number of their constituents and loved ones into health insurance. That is paying their healthcare premium, and this has also given us good number, making sure that a good number of our population are taken out of health poverty. So there are a lot of things that we have done under the Imo Care to ensure that we expand our coverage and access to healthcare services. They are very, they are not limited to what I just presented here, but I just pick out very key ones, which is we rolling out of electronic claims management system. So far, we have an efficient initial referral system that ensures knife on skin in less than 45 minutes in case of emergency. So we're able to create a very effective referral system in Imo State that links a primary provider to a secondary provider in less than 45 minutes, especially in case of emergency, through our Nexus. So we develop a very effective Nexus that connects PACs to hospitals in localities, depending on the services that is needed. And this has been working. This has helped us to save a lot of obstetric emergency cases that could have led to deaths or that could have led to maternal or child deaths. So we have also, before we even engage our providers, we sign what we call SLA, service level agreement, which is justiciable. So we don't just accredit providers and hand them our enrollees to start managing. We ensure that they come into legal binding. And it is even good that I'm speaking to lawyers, right? So we ensure, so you understand what contractual agreements like this, what they stand for. So they can sue us if we go against the agreements in the SLA. And we can also sue them in the event that they don't do as stipulated in the SLA. So this is a very strong document that has helped our providers to ensure that they render services as they are supposed to the enrollees, because they know that they can be sued by the agency. They can be taken to court. Even an enrollee can also raise an issue, and the provider is taken to court. And the provider can also take us to court in the event that we don't maybe make payments as at when due. And this has also constrained us to ensure that we pay them. So we don't owe providers because we are into an agreement with them that we must always pay them in so period of the month. So, and they must also render services. They should not deny services to our enrollees. So this very contractual agreement has also ensured that there is efficiency and there is equality in our healthcare delivery. Then we have digital enrollment platforms where people can stay at the comfort of their home and enroll themselves into the health insurance program, which is at imocare.com.ng, right? And it is also whether you are enrolling yourself from home or you are coming out to any designated enrollment center or you want to visit the state office, it is 15,000 naira per annum that you have to pay. And you can pay for your family, you can pay for 500 persons, you can adopt an entire community. You are welcome. So, and this has given rise to an expanded and increased healthcare provider network. In fact, currently in Imo State, most hospitals now want to become part of MSHA. They want to register under MSHA because they realize that majority of their fee-paying patients are now buying insurance. So when you have fee-paying patients leaving you to buy insurance, and insurance send them to different hospitals. So that is why some of them are now coming to register with us so that they become a provider, so they can keep their patients and also receive money for doing that. And this has also caused gains in value chain, both for the public and private sectors, because there's constant funding, there's sustained funding for these providers. So far, we have done we went from 0% population to 15% population. That's there are about 15% population coverage under the health insurance, with 50% target by 2026. So when we get further to the analytics, we'll get to know more about this. Then this is the formal sector. So far, 37,000. They are receiving healthcare services in Imo State. Their premium is paid. Their health insurance premium is paid by the government. They are not paying, but they are accessing healthcare services in Imo State. There is no payroll deduction. The Imo State is not taking any money from their salaries. And this also adds to the ongoing drive for our USC drive in Imo State. But one thing that is striking is that this has reduced absenteeism. People no longer say they are sick, they can no longer come to work. So it has ensured it has improved productivity, because every civil servant in Imo State now is certain that whenever they are sick, there is a healthcare package for them made available by the government. So here is our utilization chart for the formal sector social health insurance program. I think this is from analysis from November to May 2025. This is not recent. I need to September. So far, these are the services that we have. These are the interventions that we have provided to civil servants alone. You can see total utilization is up to 25,650. These are cases that we have managed, even malaria, ENT, ANC, and other forms of healthcare interventions that we have provided. Then going forward, this is the BACPF, which is a product of the National Health Act 2014. It is also a program that we designed to ensure that the poor and vulnerable ones in our communities, especially in those far-to-reach areas in Imo State, are also covered. And these poor and vulnerable groups are categorized into pregnant women, children under 5, indigent, and those living with one form of disability or the other in these very rural communities. So, but what this program has done is that this program has stimulated demand creation. It has ensured demand creation in these rural areas and also improved facility utilization. So people now go to facilities because they are behalf of activities now. We have been given the number we have enrolled there. In our first enrollment, we did 66,000 poor and vulnerable people in Imo, so that should be around 2023. The following year, 2024, we did about, the same year, 2023, we did 66,000 and 18,000. The following year, we did 40,000 poor and vulnerable populations, that's 2024. This 2025, we rolled over this 40,000 in addition with 12,000 poor pregnant women that we captured under the one we describe as 3.1, which is our maternal mortality reduction program that we are using to drive to drop maternal deaths or maternal mortality in most states. So this is for BACPF. But one thing that is very, one of the advantages or one of the ways this program has strengthened the health systems in this rural area is that because of this program, we train frontline officers in charge, frontline workers or primary healthcare workers in the rural areas. Every January is an annual program that we train them on life-saving skills for pregnant women, children under 5, and elderly. We train them and certify them. And because of this training, these primary healthcare workers now understand how to manage their patients at that level, and also be able to identify high-risk deliveries so that they don't keep a woman in the health center and keep pushing until the woman dies or the baby suffocates. So part of their training is to even be able to identify high-risk deliveries and know when to refer, because we have already built and developed a referral measures for them. So all the OICs knows who to call, the hospital to call, and when to call them in the case of any emergency, be it an emergency CS or even an elective one. They know the linkage, they know the secondary providers to call for secondary management in the event that the condition is beyond their capacity at that level. So, but part of the things that we also ensured as an agency is sustained funding to these primary healthcare facilities through capitation. We pay these funds every month to enable them, give them the enablement to render services to these poor and vulnerable people who you have enrolled into the scheme. So these payments go out every month to these PACs uninterruptedly. In the last 2.5 years, we have continued to make these payments to PACs. And this is what we have been able to achieve so far in terms of utilization. I think this is just, our utilization is around 62 point something percent, which is, sorry, our utilization is around 37.4%. That is hospital visits, which is very high. That is the number of times people have gone to these PACs to access one form of services or the other. Then the next, this is the total hospital visits, which is around 464,000. This means 464,000 cases that we have managed, that we have encountered in this program and managed. We have the total malaria, our deliveries, only normal delivery, that is the spontaneous vaginal delivery alone is around 2,874. These are deliveries that we have taken safe and sound due to the model that we are implementing in Imo State. But we have also done over 1,000. There's a place we see total referrals / surgeries. So majority of these referrals and surgeries are CS. They are obstetric emergency referrals for CS. And they are more than 1,000 that we have also handled under this program. So far, only maternal deaths too have been recorded. So this is the Imo total population coverage. So everything that I've explained so far, all the strategies, all the models that we have designed, every effort that I've done so far, this is its outcome and results in terms of data and statistics. So far, across all programs, we have enrolled overall total of 795 and 251 persons from Imo State into the health insurance scheme, making up for 14.2% population coverage. So this is where we are today in terms of population coverage in our drive to achieve USA in Imo State. So far, all this was our success in rural communities, the impact that we have been able to make through our program. So this day was the day that the Honorable Minister, the Honorable Coordinating Minister for Health visited Imo State on the implementation of the ACPF, and the agency decided to invite only women that are giving birth through CS only, not normal delivery. So all the pictures you see here are beneficiaries who have given birth through CS. So this is the pictorial representation of that event. Then this is during our enrollments in the rural communities when we go out to capture these poor and vulnerable people or groups in Imo State. So you can see the woman with double vulnerability, she's disabled and she's also pregnant. So these instances are instances where, these are cases where if in absence of any intervention such as this, most of these women resort to going to traditional birth attendants to try their luck. Some of them resort to going to prayer houses instead of having access to the needed obstetric care that they need. So this is one of those crucial moments in these people's life where MSHA comes to their rescue and enroll them into this very wonderful program where they can have access. This program has made it possible for a poor and indigent woman in one obscure locality or one community in one village. Because of this program, this woman will have access to one of the most beautiful hospitals in town, or one of the most beautiful hospitals within that place that ordinarily she cannot walk into to access care there because of the high cost of medical bills. But because we have taken these bills, we have bankrolled them. So they visit these hospitals, they give birth, and they are told to go that it has been paid for by the government. And some of them think it's a joke. They tell you, no, it's not possible. The government cannot love them that much to pay for their medical bills. Some of these bills are to the tune of 800,000, 1 million. Each left for them, they won't even attempt to visit these hospitals. Even if they do, certainly they are going to sell off a property. Certainly they are going to sell off, they are going to borrow, because the demand for health services is inelastic. So no matter whether you are rich or poor, the moment you are sick, you must look for a way to treat yourself, even if it means borrowing. So that is how bad it is. So you have to treat yourself. So some people resort to borrowing, some people resort to selling off properties, but at the end of it, they realize that this catastrophic expenditure on health further pushes these people into poverty. That is the case where you see a man who is riding Okada and the wife is pregnant and he says, yes, this man goes off to sell his Okada to be able to pay for the wife's CS. When the wife returns home, this man will no longer have an Okada to use to make income and take care of this wife and the children. So this thing can cause anxiety, it can cause hypertension, it can cause malnutrition, and anything bad that comes with poverty. That's what happens because their only source of livelihood has been taken away from them because they just wanted to pay for one medical treatment. So these are the consequences of not being enrolled or not having health insurance, because by enrolling into this health insurance, you now realize that you can have access to your access to healthcare services now becomes on your need, not necessarily on your ability to pay. So further, you see pictures of enrollment in these are very primitive rural areas in Imo State, where we go to enroll these people. And when you tell them it is free, because our PSPF programs are free, they have already been paid by the government. We also have the ones that you have to, like I said earlier, the Imo Care, that you have to pay 15,000 naira per person per annum. But this particular one that is designed that is vulnerable and is free, whenever we announce that we are coming to the rural areas to enroll, you see that almost these poor and vulnerable people abandon everything they are doing to make sure that they key in into the program, because they know that once they key in, they no longer bother about their healthcare expenditure. The government takes care of it. They only just need to be available. Go to the health center. The health center will be able to provide healthcare services to you at no cost. So this is during our enrollment in Imo State. Then this is case of women who have seen what we are doing, decide to enroll. When they enroll, they go to hospital and give birth, and they are told that it is free, that it has been covered by the health insurance policy. Out of excitement, you see them looking to get the address of the agency to come and thank the organ, to come and thank the executive secretary, Dr. Uchenna Welike. So these are pictorial evidences of those happy moments when these women came to say, we are grateful for ensuring such a very wonderful system for us. That
Thank you,
enables
Mr.
us.
Tochukwu. Please begin to round up your final remarks, sir.
Okay, all right. So I'm almost done with this presentation. So all these are pictorial evidences of the interventions that we have provided. This is when we're enrolling poor and vulnerable, pensioners, the dependent populations. This is a lady, this is a girl that had accidents, and due to lack of medical treatment and poverty, they could not access healthcare services, and they were allowed, abandoned, and the leg got bad, right? So, but we intervened. When we went to field, we met her, we intervened, and we enrolled her. In space of 2 to 3 months, she did all the necessary tests, and that leg was amputated. Currently, she has been given artificial leg, and she's back to school. This is a girl of, I think, 16 years or 17 years or thereabouts. So there are challenges to USC in most states, which is supply side inadequacies, low level of awareness, poverty, funding gap, cultural and religious bias, which the former speaker has also highlighted during his presentation. But our prospects to achieving USC in Imo State is political will, which we are grateful. We are enjoying political will and political government commitments to health, especially in health insurance in Imo State. We also have the technical capacity, given the skill sets of those of us who are implementing this program in Imo State, and our executive secretary, who used to be a director in NHIA before coming on Imo State to become as a coordinator to become the executive secretary. We're also looking at the ongoing. Currently, we are doing 2.7 million enrollments to cover about 50% of additional 50% of Imo residents. What we have also achieved so far is trust and confidence in our program. So our state actors, stakeholders, they now believe that health insurance is working in Imo State. And if you want to help your people, just go and enroll them into health insurance and put them out from the health poverty. So this is a statement made by our governor. He said, provided there is value for money on implementation of health insurance program, he will continue to give his support as a responsible government. Then this is also a statement made by our own executive secretary. He said, our expertise, dedication, and commitment to the implementation of governance health insurance policy have transformed healthcare access in Imo State, placing Imo in the national and global map for equitable access to care, given its recent ambitious ongoing efforts to enroll 2.7 million Imo residents into Imo health insurance program, which is considered the largest single enrollment in sub-Saharan Africa. It is considered that on completion these ongoing efforts, 47% of Imo residents will have access to quality health care when they need it. The Imo State Health Insurance Agency, under my leadership, will do more to end health poverty in Imo State, which only can. Thank you all for listening.
Thank you very much, Mr. Tochukwu Hibe. I'm representing Dr. Ewelike. For that intervention and wonderful presentation. It's a holistic approach to the Imo State government and Imo State health insurance agencies intervention for the health insurance scheme or agency as it were. So thank you very much. Thank you to all our participants from Enugu, from Kebbi State, from Ondo State. Thank you very much for joining us. Right now I'm going to call on Mr. Ebenezer Iguatu, the convener, for his closing remarks. Our time is fast spent. And for everyone asking for the slides, you can actually join, check our YouTube page, Nba-Garki branch. We are also broadcasting this live on our YouTube page, so you can have access to the account and the slides for future purpose and future use. Even if you don't have the slides now, but you can always rewatch the session on our YouTube page. Thank you very much, everyone. Thank you to all our speakers.
Okay, thank you, Mr. Moderator. Thank you, Mr. Ibe Tochukwu, for that insightful presentation. And in absentia, I want to thank Dr. Ifeanyi Sofo for his own session too. I wouldn't know. I know our time is fast spent, but I wouldn't know if we can take one or two questions. There might be, so that we do not shut people out at the expense of, so that we do not sacrifice people at the altar of gunning for time, because the essence of this webinar is just interaction. The question and answer segment will not be more than 5 minutes. 1-2 questions. If there is none, I take the closing remark. Okay, there's a hand up. Clinton, your hand is up. So, Mr. Moderator, let's just take that question. And Mr. Clinton, please, can you ask your question?
No, his hand is not up. He's just giving you a thumbs up.
Oh, okay. Thank you for that. Thank you. Well appreciated. I thought he raised his hand.
Someone's hand is actually up.
Okay.
So Mr. Obi Anoye's hand is up.
This is my respected elder brother. Dede, good evening, sir. Please fire your question. Okay, sorry, let me unmute you. You're muted now, sir.
Okay. Okay, Ebenezer, thank you very much. This is another wonderful outing.
Thank you, sir.
This is wonderful. Not many people know about this that is happening in Imo State. It's good that Tochukwu came around to explain this. It's a wonderful thing. So let me understand very clearly. So the agency is like an HMO, since they deal directly with the health service providers. Is that the position? It's not like a regulator, but it is an HMO.
A provider.
Sorry?
Say like a provider, a service provider.
Is it not the hospital that is the service provider, but they
like
are
more
HMO.
like the health management organization now.
Exactly, health management organization.
Yes.
So,
Okay.
so can I put out a word or two out there in response to
Yes,
this
sir.
question? Okay, so the Imo State Health Insurance Agency is a health financing agency. So we are concerned with purchase of health. So who we buy for is the enrollee. So is me or it can be you. We buy on your behalf. But who provides these healthcare services are the healthcare providers. So, but unlike the NHIA, that is the National Health Insurance Authority, which I noticed you have been describing, some of us have been describing as FHIS, that's Federal Health Insurance Scheme. Actually, is the National Health Insurance Authority, NHIA. So the difference between our own implementation modality and what NHIS is doing is that we don't use HMOs. NHIA use HMOs to purchase these healthcare services for their users, but we purchase directly for our users. So we remove that bottleneck. We remove that bottleneck with HMO. So HMO does not determine when to pay providers. They don't determine when to reimburse providers. We make those payments and we make those reimbursements. And that has ensured efficiency in the system. So we are not providers. We deal directly with the providers to ensure that. And like I said earlier, we have a very strong SLA, service level agreements with these providers, which keeps them in check and keep us in check, provided everybody's meeting their own, making sure that they cover their own ground. Thank you.
Okay, Mr. Ibe, if it is possible, I would like to have your contact, your number from my brother there, Egwatu.
No problem,
If it doesn't hurt, I also come from Imo State. So I am very, very happy at what is happening there. All right.
Okay. Thank you very much, gentlemen, for your patience, for your time. And as I always say, if you are not here, we won't be here. These webinars hold because we are sure you will attend. You attend because you are sure you will get value. So thank you very much. On behalf of the Medical and Health Law Committee of the Nigerian Bar Association Garki branch, and on behalf of our branch chairman in the person of Anthony Bamidele Ojo, want to sincerely thank every participant here. But before we come to you, let us register our profound gratitude to our speakers. Want to thank Dr. Uche Welike, and ably represented by Mr. Tochukwu Ibe, for the incisive presentation. And like my Dede Obi just said now, a lot of people are not aware of what is happening in this sector. You know, as Nigerians, we always quick to talk about the bad and not talk about the good, even when it is obvious. So I have followed the work going on in Imo State, and I said, no, let me bring Oga on board to come and share practical, because that's the purpose, practical approach, not theoretical. And like Dr. Ifeanyi Sofo said, if you are here and you do not have health insurance yet, one of the gifts you should be giving yourself now is to go and enroll, firstly for yourself, for your family members, and spread it across as many people as you can. And if you do it, you will see that you even be saving yourself some expenditure. A lot of people will call you because of health. All you do, take 50,000, register the person in health insurance facility with a HMO or a scheme. The person will not call you again. If he calls, you have valid reason to say, go and meet the people I have registered you with. And it saves you funds. So I want to thank in absentia my Oga at the top, Dr. Ifeanyi Sofo, for it has been over 10 years of me doing stuff with him in the course of advocacy, different platforms, since our path crossed in the course of health advocacy. We call him the apostle of universal health coverage and apostle of health insurance. So that is that. Then to you, our esteemed participants, we do not take your presence for granted. Thank you. Time will fail me, or it will be invidious to name names, but I have cited my brother Obi. Thank you, Dede. I have cited Madam Nkiru, our member of our committee. And of course, I won't forget our scholarly and professional moderator, Mr. Atoyebi. Thank you very much, sir. Our ebullient and dependable technical person, Damilola Alabi. Thank you, Dami. And every other member of the committee, thank you very much. In December, we have fixed a topic, but we are having a competing topic again because we wanted to do a follow-up on this. So we wanted to do a follow-up on this topic. So if we resolve that, the topic we want to do a follow-up on with this is God help me now, the application of Section 11 of the National Health Act, which is Basic Healthcare Provision Fund. It's connected to this. Now, Section 11, the government has actually mapped out some money. Someone mentioned it to me sometime in April. I debated it with him. But in September, I heard from a director at the Federal Ministry of that these monies are available. It's not just available. People are assessing it. But the question I asked them was, why is it not on air? Why are Nigerians not aware? So next month, we would most likely bring those two, the team on ground to come and tell us about the Basic Healthcare Provision Fund. In a nutshell, Section 20 is saying that no patient should be denied treatment in emergency situation. Is operational in the sense that the federal government has allocated funds. There are ambulance services. In fact, it is so operational that the first 48 hours of your being admitted, the government takes that cost. The government bears the cost of that treatment. Unfortunately, Nigerians are not aware of this. So we have to bring it on this platform. We have concluded arrangement with them. We are pleading with our other already scheduled speaker. So if he agrees, we bring them on board. If he doesn't, we take him and bring the other persons on board by next year. Thank you very much. It has always been a pleasure to convene these meetings. See you in December. God bless you. And for those who are asking about the materials, just go to YouTube, type Nba-Garki branch, then our webinars will pop up. Our webinars are recorded, including this one. We are streaming live on YouTube. So all the past webinars that you have missed, you can use that to celebrate your Christmas. Just sit down, watch all of them, so that by the time you are joining us in January, you have caught up with where we are. Thank you. Do have a pleasant night rest and a stress-free weekend. Goodbye. Sorry, the attendance form is online. If you have not filled it, please fill it. Thank you.